Herzlich willkommen.
Hello and good afternoon, and a warm welcome to our last presentation for today. We are connected live to San Francisco at this moment. Christian will be introducing our next speaker, and then we can start right away. Christian.
Hi, David.
Hi, David. Great to see you.
Okay. Also, jetzt spricht
Now, our next speaker is Dr. David Brown. He's from San Francisco in California, and his topic is vision for people with CHARGE syndrome. A bit on his background: he's a special education teacher from the deafblind segment, and he worked with the Californian Deafblind Service, and for 38 years he's been working with children with CHARGE syndrome. Enjoy his presentation, and over to you, David.
Thank you, Christian. Hello, everyone. I want to say good morning. I didn't have time to have my breakfast yet, but I do have my coffee, which is important. It's wonderful to be involved again with the German CHARGE-Konferenz. I've worked more in Germany than any other country apart from the United Kingdom and the United States. And I've worked in Germany every year for 12 years until last year when, of course, everything got cancelled. So although I'm in San Francisco, it's great to kind of be back with so many people I know and so many great memories. Congratulations to Claudia and the German CHARGE Association. It's a phenomenal achievement to have put this on the internet. And not surprisingly, there's been a huge response from people, not least because the presentations are in English. So we're accessible to a lot of people outside of Germany. My topic, it's unusual for me to have a specific topic like vision because I'm a synthesizer. I always see connections, and that's a great strength in me, but it's also a great problem because if I'm talking about one thing, I go on to something connected and then something else connected. And I'm going to begin with that with I forgot to put this slide in the show, so I'm going to go through it on my other computer. I'm not talking about clinical vision assessment. I'm not an ophthalmologist. I'm not even trained in visual impairment as such. I'm talking about functional vision. How do children use their vision? What do they think of their vision? Are they interested in vision? And what does their vision do for them? And the slide I didn't include, I say when we're thinking about functional vision, of course, we have to think about eyes, eye defects, and all kinds of aids to support visual functioning, like glasses, contact lenses, magnifying glasses, and so on. But there are many, many other things we need to know about and be aware of. First of all, the nerve pathways that connect the eyes to the brain. And I'll say more about that later. We also have to think about the brain itself because a very large number of children with visual impairment have perfectly healthy, normal eyes. But they have some kind of brain damage, which means that the brain can't interpret visual information very effectively. We also have to think about muscle tone in the body. How are the child's muscles? And what kind of problems for functional vision develop if the child's muscle tone is abnormal? If their muscles are very, very stiff and fixed, or if their muscles are very, very floppy and loose. And that's really important in CHARGE syndrome. And I'll say a lot about that today. We have to then think about broader issues like postural control. How well does this child control their body against gravity? And what do they do with their bodies to allow them to use their vision more effectively? Because it isn't only about the eyes. We have to think about energy levels. We have to think about fatigue or tiredness. We have to think about the child's health and possible health problems, which can be very distracting. We have to think about impairments in the other sensory systems. So how does vestibular damage, how does hearing impairment affect functional vision? Because everything is connected and joins up. And that's why I believe for children with CHARGE syndrome, the deaf-blind educational philosophy is the best fit. It's the educational philosophy that comes together with CHARGE in the best, most effective way. And of course, I would say that because I'm a deaf-blind specialist, and I know. We have to think about issues of distractibility and how important is vision to this child. Are they interested in vision? Is it important? Or do they ignore vision? Do we have to do special things to get their visual attention? We have to think about the child's arousal levels. Are they a bit sleepy and drowsy? Or are they hyper, overactive, very anxious, very, very distractible? How well do they self-regulate, calm themselves down or wake themselves up? Or do we have to do it? What kind of, looking at the people around the child, like the family and the people in the classroom, what are their expectations of the child? What kind of previous experience have they given the child in terms of using vision? How much motivation have they given the child to use their vision as effectively as possible? And then finally, of course, we have to think about the environment. How much does the environment around the child support them using their vision, or how much does it make using vision really difficult and complicated? Is the light too bright or too dark? Is there too much clutter? Are things all very similar color, or is there a strong color contrast? And all those kinds of issues, which teachers of the visually impaired are very good at talking about and helping us with. So if I can have the next slide, please. When I was in Germany 3 years ago, one night we talked about inclusion issues. And the next day, we took a train to Nuremberg. We were tourists. And we came out of Nuremberg station, and the first thing I saw was this poster. And it was like God intervened and sent me a message. And what it says in German, of course, inclusion, it's normal to be different. It kind of encapsulates so much about good quality deaf-blind education. And it's a reminder everybody's vision is different. I think normal vision is my vision. And you think normal vision is your vision. And your child with CHARGE thinks they have normal vision until they can learn otherwise. The only time that changes is if we lose vision ability. Like I had normal vision until I had an accident and I went blind in my left eye almost 40 years ago. So I'm aware that my vision is no longer as good as it used to be. But everyone's vision is different, and visual functioning varies according to all sorts of things, like in that list that I just read out to you. So the next slide, please. This is a quote from a very influential American teacher, and she's making this very point. And what she says is, that visual functioning is related in part to the condition of the eye. So we do need the vision specialists, the ophthalmologist, the optometrist, the optician. We need them to examine the eyes clinically to give us information which could be very important and very helpful. But functional vision depends on more than just the condition of the eyes. And then she lists a lot of those things, and I've underlined some of the words because I think things like the child's experiences, their motivations, their needs, their expectations, their need to satisfy their curiosity, and their need to feel personal satisfaction, all those things are going to influence functional vision behaviors. And if you look at those words underlined, they're all related to emotion. It's all about being curious, being interested in the world, wanting to feel that you're functioning effectively, wanting to feel good about yourself. And that's a reminder for us that we need to make sure our educational approach builds success into everything we do. Success for us, but more importantly, success for the child that we're teaching. And the next slide, please. This is a list I made, I think, earlier this year. People often talk about children with charge being lazy, which always surprises me because I wish they were a bit more lazy sometimes. Much of the time, they seem to me to be very goal-oriented and very driven. And I thought, well, if you don't see well, you're more likely to get tired than your peers who see well. And then if you don't hear well, we live in a sighted hearing world. So just coping with impaired vision and impaired hearing demands more time, more attention, more energy, more concentration. But then when you look at this list, I won't read it, but you can see it's a big list. Every one of those 21 problems carries a risk of making the person tired, of putting them in a position where they need breaks, where they need to have a little rest. Then when you look at that list and you think of your child and you realize, my goodness, I put this list on Facebook and a parent in England contacted me and said her daughter had 9 of these and they'd never realized how hard she must be working to be in a general education classroom at school, almost keeping up with all the other children in terms of her development. And then someone in the United States wrote and said her son had 19 of those 21 issues. And they'd always been concerned that he seemed lazy, that he often was not engaged, that he often needed to lie on his back and all those classic charge behaviors. And I think we need to remember that for people with charge, using vision might be a very tiring activity in a way that it simply isn't for us. So the next slide, please. This is a cross-section of the eye. I always like to show this because many people don't actually know what the eye is. They don't know the design of the eye. And if you look at this cross-section, on the right-hand side, you have the front of the eye, which is the part you see when you look at someone's face. You have the eyelids, and then you have the very front of the eye. And behind that, you have the lens. Then you have this large ball, which is filled with a thick, clear fluid. And then at the back of the eyeball, you have the retina all around the lining, all around the inside at the back of the eye. And then you see the optic disc and the optic nerve on the left going away to the brain. And the idea is that light information comes from the right. It comes into the eye, goes through the cornea and the lens, travels across this clear fluid to the retina. The retina turns that into electrical energy, sends it up to the optic disc, and then it goes through the optic nerve to the brain, and the brain interprets it. And in charge, there can be problems all the way through the eye, from the eyelids themselves right through to the brain and the visual cortex. So if you hear about eye conditions, or you see your child doing something that suggests they're trying to cope with the problem, it can be quite useful to remember this cross-section of the eye to help you think about where things might be going wrong. So the next slide, please. Putting it very simply, if you have a newborn baby and there are visual problems, I think there are probably just 4 main issues that will give the family the idea that the child might not be seeing properly. And I would say that statistically, it's mainly the prime caregiver of the baby, who's usually the mother. They're usually the first person to notice one or more of these issues. And sometimes they're not listened to and they're not taken seriously until the child is a little bit older. So first of all, the eye might not appear normal. There might not be an eye. It might be missing, or it might be unusually small. It could be unusually large, but something about it would look strange. And we know in CHARGE syndrome, if the child has a coloboma or part of the eye missing, in the iris at the very front of the eye, you can see that straight away. And I will show some pictures of iris coloboma, and you can see that the problem is very visible. Then the eyes might move in a strange way. The eyes might roll around as if they're following something, but there's nothing there. Or more commonly, the eyes might flicker very quickly. This flicker is called nystagmus. And I think usually most of the children I know, the eyes go side to side, but sometimes nystagmus goes up and down. And some children, it alternates side to side and up and down. That suggests that the eyes are not able to focus effectively. And as a result, the muscles lose control and the eyes flicker. It's an involuntary movement. Then the child might have unusual gaze or head positions. And we know in CHARGE with retinal colobomas, the upper visual field is often missing. So the children have to do this. They have to bring their head up because they only have lower visual field, and they have to lift that visual field in order to look ahead. And sometimes they do what's called eccentric viewing. They look to the side, or they look above, or they may even look below in some cases, rather than looking directly. And it's very important not to keep pulling the child's face and saying, look at me, because they might be looking at you by looking to the side. And the child might not have typical visually directed behaviors. So they don't seem to see things. They don't seem to look at things. And the next slide, please. I've organized this as the five types of vision loss, but I'll go through very quickly with some of them. And the first one is the one I think we're most familiar with, which is the loss of visual acuity. And it's why now when I'm reading, I have to wear these glasses. I can't read the newspaper without wearing my reading glasses. And that's age related, and that's very normal. And if I was in the room with you, I would point out the large number of people who are wearing glasses, which suggests there is this kind of problem. And if we look at the next 3 photographs, This is supposed to be normal acuity, and the next picture shows a problem with visual acuity, and the next picture shows a much more severe problem with visual acuity. That's just to give you a vague idea what I'm talking about. I would just say about acuity, it is possible to have charge and have problems with visual acuity. Nothing to do with collarbomas at the back of the eye. And if you think there's a problem, you need to explain to the ophthalmologist that you think it's a problem with visual acuity. If the child has retinal collarbomas, the ophthalmologist is always very interested because retinal collarbomas are rare and unusual. And sometimes when they see your child has retinal collarboma, they will ask their colleagues to come and have a look because it's so interesting. If you then say, do you think my child should have glasses? They might say no, because glasses won't help with retinal collarboma. But you might mean, I don't think my child sees things in focus very, very clearly. So you do need to explain that's why you're asking about glasses, not because the child has a retinal collarboma in the eye. You're probably familiar with strabismus. You see in this picture, the eyes are not aligned. They're not working together. And all those kinds of visual issues that are found in the general population can also be found in children with charge. And it's important not to miss them because we're looking at more charge-specific eye problems. These need to be dealt with just as importantly. And then the next slide, please. I'll talk about this a lot. Loss of visual field. Now, what we call normal visual field is what most of us are born with. Each eye has a visual field, and it's a big kind of round area where we can see things, even if we're not looking directly. I can see my bed, which is right over there. I'm not looking at it, but it's there. I can see my backpack on the floor. I can see a glass of water on the floor. But I'm looking at the computer screen. And the two eyes' fields of vision overlap in the middle to give really, really effective vision when I'm looking at something in detail. Now, I lost the vision in my left eye 40 years ago. So I didn't realize for decades that I always hold my head a little bit to the left because I only have my right visual field. So I turn my head a little bit to bring that visual field over to help me see on the left side a bit. And I'll come back to that. But in charge syndrome, loss of visual field is very common. And the next slide, please. And there's one more picture, thank you. Ptosis, the word ptosis is used to describe an eyelid which is too low. It doesn't open properly when the eyelids open. And you see two pictures here. Both these people have ptosis with their left eye. They open the eyes and one eye opens normally, but the other one doesn't open completely. And in charge, this problem is usually associated with facial palsy, which, as you probably know, is a significant charge feature stemming from cranial nerve damage. And if there's facial palsy, it's usually one-sided, and one side of the face is kind of compressed and drops together. The other side gets a little stretched as a result. And on the side with the facial palsy, that lid might well not open properly. And sometimes the children develop their own behavior to lift the lid. And because children also self-stimulate by poking the eyes, if a child does this to lift the lid, very often people say, take your finger away, take your finger away. It's so important to look carefully at what the child is doing. they might not be poking their eye. They might be pulling. Sometimes they're not even on the eyelid. They're up here on the forehead, but they're pulling the skin up to try and move the eyelid out of the way. The next slide shows that I put this in more as a joke. I found this on the internet. It's a demonstration of visual field with ptosis, and you see that the eyelid is blocking the picture. The next slide, please. Here you see an interesting picture. This young man has, if you look on the right side, he has very severe ptosis on his left eye. You see how his eyes are open, but the left eye is hardly open. And then you see in the picture on the left, if he thrusts his jaw over to the right, it has the effect of opening up the eyelid on the other side of his face. You see how he's done that with his jaw, and the eye has opened. And this is another example of why we need to observe children closely and carefully, and not just jump to assumptions that might not be correct, that could actually be wrong. The next slide shows somebody, an older person, actually doing the eyelid lift. The next picture shows somebody who had bilateral ptosis. Both eyelids were too big. They've had surgery to cut open the lid, remove a thin strip of skin, and then stitch the lid together again, so that now the eyelids are a little shorter. And this is sometimes done with children with charge to open the eye up more effectively. The challenge, of course, is doing it just the right amount so the eyelids still close, because the eyelids have to close. Now, in facial palsy, I said one side of the face, the eye tends to be compressed with the lids. The other side is often stretched. And in children with charge, that can be a particularly dangerous problem if the eye is kind of stretched out. When the eyelids close, they don't close completely. So the front of the child's eye is always exposed to the air. The eyelids close to lubricate the front of the eye, and that's really important. It has to be kept clean and moist. So if the eyelids are not closing, that child will need drops very regularly in the eye. And I mean very regularly, including in the middle of the night, because the eyes don't even close when the child is asleep. And what is sometimes done for that problem, as you see here, a small weight is inserted in the upper eyelid, surgically inserted and then stitched in, which makes that eyelid a little heavier and brings it down to close. Now, I know some families who were given this option and decided it was too much, and they're more comfortable with giving drops every 3 hours, 4 hours through the day. And I know a number of adults with charge who do the drops themselves just as a habit. They hardly even think about it. Now I've got 3 more pictures. This, talking about field loss, there are different kinds of field loss. In this picture, you see a simulation of peripheral field loss. In other words, the visual field is missing except for fine vision in the center. So a person with this kind of field loss would probably be able to read. They would be able to do all kinds of fine visual work like stitching and sewing, but they wouldn't be able to walk around very safely. They would probably need a white cane or a service dog because they don't see the environment around them. The next picture shows a simulation of the opposite. Here, the peripheral field is complete, but central vision is missing. So this person might have no problem with mobility. And they might move around in the world very effectively, but they probably won't be able to read. They won't be able to do any kind of fine vision activity because that central field is missing. And I'm just looking. Oh, I'm okay. We'll take questions at the end, of course. And then the third picture, again, is a simulation of very mixed loss, where lots and lots of the retina has damage. So you get this very pitted picture of the field. And this brings me specifically to retinal coloboma. So the next slide. And here you see, if you look at the front of those eyes, on the left side, you see an iris coloboma. The iris should be a nice black circle, but there's a whole extra piece, which is the iris coloboma. And I will talk about that in a moment. But now I'm talking about retinal coloboma. If you look at the picture on the left, the red area is the retina at the back of the eye. And you'll notice it doesn't go all the way down. Towards the bottom, there's an edge, and then the rest of that part of the eye is all white. That's the coloboma. That's a place where the retina didn't develop, which is, this is very, very common in CHARGE syndrome. What that means is that eye may well see very well most of the visual field, but the retina at the bottom isn't there. So there will be a dark area in the visual field. But you see where it says macula, that kind of yellow oval, that is the area of very fine vision. That's the part of the retina we use when we're reading or, putting in a screw with a screwdriver, or we're using fine central vision. And in that eye on the left, the coloboma has missed the macula. So that eye, in theory, would have normal central vision. But now if you look at the picture on the right, you will notice here the white area is much bigger. This is a much bigger coloboma. Colobomas can be different sizes, different shapes. There can be more than one in the eye. You might meet a child with one eye with a coloboma on the retina and the other eye normal retina, or there might be colobomas on both retinas, and the colobomas will always be different. They'll always be different sizes and different shapes. The eye on the right of this picture has a much bigger coloboma, and you will notice it comes up where the macula should be. So that eye doesn't have fine central vision. So fine visual discrimination like reading will not be possible for that eye. Now, another thing to talk about before I leave this slide is where you see the red area meeting the white area, you see that line. That line where the red meets the white, the retina itself is unusually thin. And along that line, the retina, there's a danger of the retina tearing, of a little hole appearing. And the problem if that happens is that the fluid in the eye gets through that little hole and it comes between the back of the eye and the retina. The retina is a bit like wallpaper glued. We have wallpaper glued to the wall. We have the retina stuck to the back of the eyeball, around the inside, stuck to the eyeball. And if you think of wallpaper on a wall, if there is a leak in the roof, the rainwater comes down the wallpaper. It's not a big problem, but if there's a little hole in the wallpaper, the rainwater goes behind the wallpaper, and soon more and more of the wallpaper comes away, and then it all falls down off the wall. And if the fluid in the eye can get to the back of the retina, it tends to go in there more and more very quickly. This happened to my eye after my accident, and I sat for about 7 hours one day, and I watched a black spot grow bigger and bigger and bigger, and I knew exactly what was happening. And after 7 hours, my eye was completely blind. I mean, the blackness was like I couldn't imagine. And I went to the hospital the next day, and the following day I had surgery to try and they got most of the retina back for me. What this means for a child with retinal coloboma is they shouldn't be exposed to too much high impact, especially with the head. So you don't want head banging. You don't want them playing rugby or American football. You don't want them diving headfirst into water. You don't want them doing things like wrestling and kung fu and all those things that involve a lot of impact to the head, because one of those impacts might be enough to make a small tear in the retina, in which case the retina could detach from the back of the eye, and it's known as a retinal detachment. Now, there's no pain involved. There are no pain receptors at the back of the eye and the retina, so you don't feel it happening. And I know many children who've gone for ophthalmic examination, and the doctor discovers that the retina in one eye is detached, and it may have been detached for a long time. So periodic eye examinations are a good idea, and trying to avoid high impact to the head, if possible, is a good idea. The next slide, please. I know I'm going very quickly through this, but I do think I do want to get through the main points here. Something complicated. The visual image that comes into the eye, as it comes through the cornea and the lens, it is reversed. So everything we see on our retinas is upside down. But then when the image goes through the optic nerve to the brain, our brains automatically turn it the right way up. It's a miracle. But why this is important to know, most retinal colobomas are on the bottom of the retina. The retina in a fetus, the eyeball forms from the top. And over time, it develops down and it develops as a ball. And then it meets at the bottom and it kind of zips together and you have an eyeball. And similarly, as it develops, the retina develops down. If something is going to interrupt that, it will probably, the top will form. If it interrupts the top as well, then there will be no retina. And that's possible in CHARGE, but unusual. So usually there's the top part of the retina and then a coloboma, whether it's big or small, or whether there are two of them or three of them, they tend to be at the bottom. But because the visual image is turned upside down, what's missing is the upper visual field. It's the bottom of the retina, but the top of the visual field. So if you look at this picture, you see the man standing there, the little matchstick man. If that eye had a large retinal coloboma, it would be at the bottom. So it's the man's head that would be missing and his shoulders. So in terms of visual perception, that eye would see the man's legs and maybe his body, but they wouldn't see his head unless the head was tipped back in order to bring his head into view. And the next picture shows what the ophthalmologist sees when he looks in the eye. That light, the large light area, is a very large retinal coloboma in the eye. And that's what they see when they dilate the eyes and put the bright light into them. And the next picture is a woman I know with CHARGE in Canada who posted this on Facebook to demonstrate her eccentric viewing. And I instantly asked for permission to use the picture. This is her looking at the camera. And this is, for teachers, this is such an important point. You must not tell that woman to look at you when you're talking to her. If she were a child, you shouldn't put your hand on her chin and turn her head round to make her look at you. Really important. And then the next picture is an old picture from an American CHARGE-Konferenz. The children have been posed for a photo. They're all quite young with CHARGE syndrome, so nobody's being very obedient or compliant. But you will notice 3 children with very typical CHARGE viewing posture. The 2 boys on the floor are very low down, so their problem with missing upper visual field is more severe because they're not up, they're down on the floor. So they're having to extend their heads up very dramatically to look at the camera. The girl on the right sitting on the couch is much higher up. So you notice she's only extending her head back a small amount in order to bring her visual field up. The next slide, please. These are 2 photographs of iris coloboma to give you an idea what they look like, and also to give you an idea of the fact they can be different shapes. And usually it's quite possible to have a retinal coloboma with no iris coloboma, but in my experience, most children who have an iris coloboma, the coloboma extends right back in the eye to the retina as well. This doesn't affect visual field at all, but it creates a problem with dealing with bright light. If you think of the pupil at the front of the eye, that black circle, in bright light, that circle gets smaller to shut out the bright light. And when it gets dark, that black circle opens up and gets wider. And this happens automatically. If the pupil has this extra bit, when the light gets bright and those pupils close, the coloboma can't close. So the bright light still comes into the eye and it can be quite painful. So the children develop what's called photophobia, where they don't want to look. They cover their eyes, they screw their faces. They don't want to go outside the building because the sun is shining, and so on. The next picture shows a boy I work with, and you can see his iris coloboma very clearly because my flash, I took the photo. He was having a meltdown at a CHARGE conference and overstimulation. But you can see how my camera has caught the reflection of his retina because that eye wasn't able to close down in response to the flash. And the next picture shows a young man wearing a cap with a pronounced front to it, and also dark glasses. And many children with CHARGE need a hat with a visor or dark glasses in order to cope with bright light. And the next picture I put in as a joke. Bright light or glare can be a problem. And I like this picture because I pretend that little boy has fallen over because of the bright light coming off my bald head. That's not, he was lying down because we were playing with him lying down. But it's just a reminder that bright light and glare and shiny surfaces can be a big problem for these children. Next slide. I won't say too much about this one, but it's possible to lose contrast sensitivity. And I have 3 pictures just to demonstrate that kind of difficulty. Here you see everything's the same color, so it all tends to blend. And the next 2 show staircases, and you see how confusing this would be, especially if you only see with one eye. We have depth perception. We can gauge the height of the steps because we have 2 eyes and we have stereoscopy. If there's only one eye looking, like in my case, I don't have depth of vision anymore. So it's hard for me to know how high a step is or how low. And you may need to think about that. The next slide, please. This is a very important one for charge, and it really extends a lot. Loss of ocular motor control. So a loss of ability to control eye movements. And in charge, this extends from the eye muscles through all the muscles of the body. And I wrote an article about vision issues in people with charge. And I really make the point very strongly that we need to think about muscle tone through the whole body. We need to think about posture, and we need to think about postural control. So in the next picture, you see the eye muscles, and there are pairs of them. And they're the muscles that allow us to move our eye up and down, side to side, or round in a circle without moving our head, just moving the eyeball. Now that needs normal muscle tone to operate under control. And we know that people with charge generally have a low muscle tone, and they have to exaggerate muscle tone sometimes in order to function. Sometimes the children might have high muscle tone mixed in, which means their ability to move their eyes in the socket may be impaired. But it also extends through all the muscles of the body as well. So the next slide, you will have to press several times, I think, Claudia. Perfect. This is the equilibrium triad. We talk about equilibrium or balance, and that really develops from three senses working together: the proprioceptive sense, the vestibular sense, and the visual sense. And we forget that vision is very important to our balance. We use our eyes all the time to keep ourselves upright. And if we're going down the side of a hill or we're climbing a mountain, we use our vision even more importantly to help us to maintain good posture against gravity, as well as using our proprioceptive sense in our muscles and joints, and also using our vestibular sense in our inner ears. And we know all three of those senses might be missing or impaired if you have charge syndrome. And I do whole days about this, so I'm now going to condense it into like 4 minutes. But if we go to the next slide, and I don't know how useful this is a clinical definition of a reflex. This is a reflex that connects our vestibular sense with our vision sense. And what this reflex does is, if I look at the picture of Claudia on my computer, and I can look at her eyes. Now I can move my head in all these ways. I can sway around, I can swing my head, I can go down. And all the time my eye is fixated on Claudia's face. It's not a problem because I have a normal vestibular sense. But if you impair my vestibular sense or even take it away, first of all, I would probably fall off the chair. But if I could hold on to the chair, the moment I move my head, my eyes go with my head and I don't look at Claudia anymore. I have to search. Oh, there she is. Now I find her. But then when I come back, my eyes go over here and I lose her. It's my vestibular system that keeps my eyes on the target, and it works very well. If you have charge syndrome and your vestibular system isn't working, every time you move, when you're trying to visually fixate on something, the movement will pull your eyes away from what you're looking at. So you're going to have to find ways to stop your body moving and stop your head moving so that your eyes can continue to look. And the children learn this themselves. They learn about the importance of this reflex, even though they've never heard of it. And they learn ways to cope with the problem because they don't have that reflex working. And if we can go through the next two slides very quickly, please, because I don't want them. They're too complicated. And then we get to the picture of the boy watching television. This is an old photo, and I just make the point that this is an absolutely normal way to watch television. If you have no vestibular system, your upper visual field is missing, you have poor tactile and proprioceptive perception, and your muscle tone is very low and very floppy. And we don't want children laying in this position too much for too long, but at the moment, this is functional. And now I'll show you a little group of pictures, and this will be very familiar with you, all very typical Charge. This boy has been playing soccer with me and a few other people at one of our picnics, and he's worn out. He goes to his grandmother, he finds her phone. He lies on the floor. He brings one ankle up on the other knee to fix his body so he knows he's safe. And then he starts with great skill. He looks at the phone and he starts to scroll through her address book with great skill. He can't do that if he's sitting up. He has to be lying down at this age developmentally. And then the next picture is one of my favorites. This boy is on a couch and he's using the armrest to support his head. He's on his knees. He's using his hands for extra support, but he can bring that hand up and use the touch screen to operate the tablet when he needs to. And you see how cleverly he's taken away all the difficulty of controlling his body and keeping his head still by taking this posture. And then one of my all-time favorite pictures, this is Jonas, of course. A couple of years ago, Claudia gave me a whole group of pictures of him. This is taken from above, looking down, and his legs are on the back of the couch, and his back is leaning down, and his head is on a cushion on the seat, and his legs are twisted. And we need to honor what the children have achieved when they do this. Okay, we don't want Jonas doing this for hours every day for the rest of his life. But at the moment, this allows him to do fine vision work and visually directed movement, hand-eye coordination. And the next picture is even more alarming. This is the best way at this stage for this child to use her tablet, upside down, with the feet holding on to the baby gate and standing on the hands and the head. And again, bringing one hand up to free it to operate the touch screen. And then the next picture, if your upper body is weak, if you have weak hands, arms and shoulders, which is fairly common in Charge, if your lower limbs are stronger, why not lie on your back and use your feet to hold things steady? If he sits up and holds this in his hands, it's going to move all over the place, and his head is going to be dropping all the time. In this position, he can maintain. And then the next picture was taken at the CHARGE-Konferenz 2 years ago by a parent I know who's a wonderful professional photographer. And at the party on Saturday night, she found a group of young kids all lying on one side looking at cell phones, you know, the modern obsession with cell phones, which babies now are born with, I think. And she sent me the photo and she said she listened to me talking about this at 4 o'clock. And 3 hours later, her child, and as she said, there were 6 kids doing this, but she only took a picture of 3 and she wished she'd come back and got more of them. And this is why the next picture shows the little room, Lily Nielsen's little room. This is why this is such a good piece of equipment for young children with Charge, so that they can be on their backs and effectively using vision and visually directed reach. And next to it is a British, what we call a rip-off. Somebody in England made a copy of it. And then the next slide what these children are doing is they're fixing the body to fix the head, to fix the eyes, so they can use their vision in the best, most reliable, and most comfortable way. And that might be the most important point I'm making today. If children are interested in vision and using their vision, they will find a way to use their vision in the best way for their needs. And that's really important. These children are not idiots. Most of them are not mentally ill. And they know what's working and not working for them. And not surprisingly, this is all about them, not about us. And whilst I'm aware that many of these postures are not healthy long term, there's a point where we have to allow these children at these stages of development to adopt these postures for other reasons. But we also need to be working to improve muscle tone, to improve self-regulation abilities, to improve postural control. And it does come, and it does happen. And then very quickly, I can't believe I'm on time. That's wonderful. The last of the 5 types of vision loss, and this is a complicated one, is loss of visual processing. And that's a very complex topic, but I did make a point about it at the beginning, where it might be that the problem is in the brain, not in the eyes. And it's possible for children to have this kind of processing difficulty, but it's very hard to assess what's due to low muscle tone, what's a visual processing problem, what's due to ocular defects. All those things are layers on top of each other, very hard to understand. And just to make you smile, if you haven't smiled yet, the next 3 pictures will make you smile. The next picture, please. This gives you a visual processing problem. And because we're all sensible adults, we know what's happening in this. We know that cat doesn't have big antennae because we know about cats and we know about dandelions. The next picture is even better. And again, we know what's happened here, but we laugh because that looks like the man's head. That yellow thing looks like his head. And then the next picture again, we know what's happening. This isn't a dog woman or a woman dog. I mean, it might be a female dog, but it's certainly quite separate from the woman. And the next slide, please, what this reminds us is that we don't see with our eyes, we see with our brains. You know, the eyes have to collect the information, but the brain is critically important. And if you're trying to assess a child's vision, it's important to think about the eyes, but you need to think about the child, the whole person. Like the very first thing I talked about, we need to think about their previous experiences, their emotions, their motivators, their health, their postural control, the environment, and equally, the next slide, with hearing. We don't hear with our ears, we hear with our brains. We need ears and we need the cochlea, but we also need a brain attached because that does the active work of hearing and interpreting. And the next slide, what do you do? If you've ever heard me present, you know I go on and on about this. Every child I meet is doing things, and that's what I'm interested in. I'm interested in what the parents think. I'm interested in what the teacher thinks. I'm interested in what the doctors think. But I'm most interested in what that child is doing and what they're interested in and what they seem to like or they seem to need, because that's where I'm going to start to build my assessment and from that, my educational plan. So don't be dismissive of the child who lays on his back, rocking side to side and clicking his tongue. Don't be dismissive of that because he's giving you crucially important information for your assessment. And that's where your assessment should be beginning. And my very last picture, and this, I've great affection for this. This takes me back to my early days in California. This is a 12-year-old with charge who is using fine vision in one eye with just a little piece of lower visual field. But in order to do it, she has to lie down. She has to bring one ankle up on the other knee, and then she has to push 2 fingers of her right hand against her lower lip, against her teeth. And once she's done all that, she can move that eye around the pictures in the book, looking at the fine detail. But at this stage of development, at 12 years of age, if you said, don't lie down, it's the middle of the day, you mustn't lie down, you're 12 now, you must sit up on a chair, you must be at a table, what you're doing is making that child functionally blind. And if you then walk away, as happened with her, the first thing she does is stop being functionally blind by getting back on the couch, bringing one ankle up on the knee, pushing her fingers against the lip and using her vision. She knows what works best for her. So that was 62 minutes. That's amazing for me. Very unusual. And thank you for listening. My main goal in life is to be useful, always. And when people say, oh, that was great, my first thought is, but was it useful? I'd rather it was useful than great, you know, if it's possible to have one or the other. Because in a couple of hours or next Monday, you're all going to be involved directly with children. And that's where what we're talking about here needs to come into play. So now we have questions, I think.